I'm Dr. Naveen Tiago. I've been an orthopedic surgeon for many years. And one of the most common things I hear from patients when they first come to see me about tendon pain is this. I've tried everything, rest, physiotherapy, anti-inflammatory, medications, injections, different braces, exercises, and nothing has worked, doctor. When I ask them to walk me through what they tried, and almost every time I can see exactly why it didn't work, not because they failed, not because the tendon is beyond help, but because every single thing that they tried was aimed at only one thing, that is reducing the pain. And here is what years of clinical experience and the research evidence agree on. Pain reduction is not a recovery, it is just the beginning. So, fourth video on this tendon series. I want you to take you through what evidence actually says about is how the tendon pain is properly treated and not what is popular, not what is commonly recommended. What the research supports and why so many people, despite trying so hard, are still stuck with this tendon problems. Here is what you will get from this video. Specifically by the end, you will understand why rest alone keeps failing you, what isometric exercise actually does, and why it matters in early rehabilitation. You will understand what progressive loading means, why it is the core of any evidence-based tendon rehabilitation program and treatment. And you will have a clear framework grounded in research for understanding what a properly structured approach to tendon rehabilitation should look like. This is not a treatment plan. This is a clinical education, and that the kind that I give my patients. Before we begin this rehabilitation, this video together, if you are short on time, jump to the key takeaways at the end. But if you want to truly understand this, stay with me. It is worth it. The video is for general education purpose only, and individual presentations may vary significantly, and all treatment decisions should be made in consultation with qualified healthcare professional. Before we get into the evidence, let me briefly bring you up on what we have covered so far in this series, because this video builds directly on those foundations. So video number 1, we talked about tendon pain, why tendon pain feels so confusing, and why pain doesn't always match with what we see on the scan, and why the same activity can feel different on different days, and why the warm-up effect, pain at the start, better in the middle, and worse later, is not a random phenomenon. It is the tendon telling you something specific about load and the capacity. That was video number 1. Video number 2, we went deeper into why tendon problems don't behave like normal injuries. We talked about relapse pattern, rest, feel better, return, pain comes back, and why that cycle happens again and again. The core message of that video was this: your tendon is not suddenly injured, it is gradually failing to adapt. And rest removes the symptom without addressing what is underneath. In video 3, we introduced the tendon continuum model developed by researchers Jill Cook and Craig Uda. We walked through the 3 stages: reactive, disrepair, and degenerative stage, and explained why the same diagnosis can mean very different things depending on where in that progression the tendon is. The key insight of the video is same tendon, different stage, different problem. Treating them all the same is one of the most common reasons tendon problems do not resolve. So now with that foundation in place, the question becomes, what do you actually do about it? That is what this video answers. Let me start with the principle that changes everything once you understand it. Your tendon does not only need protecting from load, it needs the right load at the right time. The tendon is not a passive structure, it is a living, adapting tissue, and it responds specifically and directly to the demands placed on it. Load the tendon appropriately and it adapts, strengthens, and builds the capacity. Remove the load completely and it loses the very properties it needs to handle the normal activity. This is why, in my clinical experience, the patients who do worst are not always the ones who pushed too hard. They are often the ones who rested too long, because rest took away the pain and gave the illusion of recovery, while the underlying capacity of the tendon, it never changed. Now I want to be precise about something when I talk about what works. I am grounding this in specific research. Most of the high quality evidence in tendon rehabilitation comes from studies on 2 tendons. One is Achilles tendon, which is behind the ankle, and another is patellar tendon, which is in the front of the knee. The principles that emerge from that research are broadly applicable across tendon presentations. But how you apply them depends on which tendon is involved, which stage of the pathology you are, and then your individual clinical picture. This is why I always say, please do not self-prescribe from the YouTube video. Use this to understand the framework, then work with someone who can apply it to you specifically. Now let me take you through the evidence. I am going to break this into two parts. The part one, managing the pain so that you can actually load. Part two, rebuilding the capacity through progressive loading. These are not the same things, and confusing them is one of the most common reasons tendon rehabilitation treatment fails. The part one, managing pain so you can load. The first clinical challenge I face with almost every tendon patient is this. The tendon is too painful to load. And if it's too painful to load, rehabilitation cannot begin. So, if you watching this, you will know exactly what I mean. You have been told you need to exercise the tendon, but every time you try, the pain stops you before you can even start doing something. And that is where most people lose confidence, and this is where a finding from research has genuinely changed how I approach early rehabilitation. A study in athletes with patellar tendinopathy compared with two types of exercises. One is isometric contractions where the muscle works without any movement, and isotonic exercises which involves full movement through the range of movement. The isometric exercise produced immediate substantial pain relief, and that relief was sustained for 45 minutes after the session ended. Now the limitation in this study here is, this was a small study, only 6 athletes, and it was very specific to patellar tendinopathy. We cannot yet generalize these findings to every tendon or every patient, but the clinical implication is significant and it aligns with what I now see in my practice. The proposed mechanism is cortical. The people with tendinopathy appears to have abnormally high level of inhibition in the motor system, and a system that controls the muscle fibers. An isometric exercise appears to release that inhibition, which reduces the pain and actually improves the muscle strength at the same time. So, in practical terms, isometric exercise gives us a window in which tendon is accessible and is less painful and ready to be loaded progressively for next stages. But I want to be clear about this. The isometric exercise is not the treatment. It is only the entry point to the treatment. The patient I see who do isometrics and stop there because the pain went away, they are the ones who come back to my clinics 6 months later or several weeks later. Because the pain was managed, but the capacity was never rebuilt. Now, part 2. Rebuilding the capacity through progressive loading. Once the pain is manageable, the real work starts now. And the real work is progressively loading the tendon. This is where the research is more consistent and most compelling. The load-based rehabilitation exercises that progressively challenges the tendon and the surrounding muscle tendon unit is the primary evidence-supported treatment for tendinopathy. Let me tell you about a specific study, particularly clinically relevant. It's a randomized controlled trial, which is the highest level of clinical evidence, compared a heavy, slow resistance training against the traditional centric exercise program in 58 patients with chronic mid-portion Achilles tendinopathy. But the groups trained for 12 weeks, both groups were followed up for 1 year, the results were clear. Both approaches produced significant and meaningful improvements in pain and function, and those improvements were maintained at 12 months. There is new vascularization reduced, the patients returned to activity, and the heavy slow resistance groups showed their compliance, 92% compared with 78% in eccentric groups, and a higher patient satisfaction at 12 weeks. Now I need to give you the appropriate context. The study was conducted in recreational athletes with chronic mid-portion Achilles tendinopathy specifically. And these results should not be directly extrapolated to insertional tendinopathies. Insertional tendinopathy is a problem where it is concerned with the attachment of the Achilles tendon or other tendon presentations without careful considerations. But what this study alongside the broader evidence base tells us is this. When you load the tendon progressively with appropriate magnitude and appropriate recovery, meaningful and lasting clinical improvement is achievable. The key word is progressively. This is not about working through plan. This is not about aggressive loading. It is about starting a load the tendon can currently handle and increasing that load systematically as the tendon capacity grows. In the heavy slow resistance protocol, the load increased every week. The repetition decreased as the load went up. The recovery was built into the program. This is intelligent loading. Enough stimulus to drive adaptation, never so much that it provokes a reactive response and sets the rehabilitation back. The part most people miss is, now I want to address something directly because I see this mistake repeatedly in the clinic. Many patients come to me having had treatment focused on entirely on pain, injections, anti-inflammatory medication, these therapy, shockwave therapy, and also many therapies. And some of these treatments have a role. I'm not dismissing them, but the evidence is clear on this point. The interventions directed solely at pain have minimal effect on the deficits in the muscle performance and tendon loading capacity that drive the problem. And without addressing those deficits, the pain will return. It is a failure of the treatment target. The pain is a symptom, the load capacity is the underlying problem. If you only treat the symptom, the problem remains, and this is exactly the mechanism behind the relapse pattern we discussed in the video 2. The person who rests, feels better, returns to activity and then relapses. Not because they did something wrong, because the tendon's capacity was never rebuilt to match the demand being placed on it. The clinical framework now, let me give you the practical framework that the evidence supports. This is not a prescription, this is a model of understanding what a properly structured rehabilitation program should address. First, load management from the start, not complete rest. Identify and reduce the specific loads that are provoking the reactive response while maintaining as much activity as possible. Second, pain-safe entry loading when the pain is limiting rehabilitation. Isometric exercises may provide a clinically useful window. Reduce the pain first, then progress. Third, progressive resistant loading. Systematic, gradual increase in load over weeks and months. This is where tendon capacity is rebuilt. This is the core of the program. Fourth, I tell every patient who comes to see me about tendon pain the same thing. This will take longer than you want it to. The research consistently shows that meaningful structural and functional improvement takes weeks to months and not days. The patients who recover are not the ones who found a shortcut. They are the ones who understood the process and were very consistent with the treatment protocol. In the next video, I am going to talk about something equally important, because in many years of clinical practice, I have seen patients with access to the right treatment still fail to recover, not because the tendon could not, but because of specific avoidable mistakes in how the rehabilitation was approached. And if you have been dealing with tendon pain for months or years and nothing has worked, that video may explain exactly why. The key takeaways in this video, if you remember one thing from today, the tendon does not only need protection from load, it needs the right load at the right time, applied consistently over time. Isometric exercise opens the door for the treatment. Progressive loading builds what is needed, and pain reduction alone without rebuilding the capacity is why so many people are still struggling despite having tried so hard. If this is helpful, you understand your condition better, please like this video and share it with someone who might benefit from this video, and subscribe for more evidence-based content. Join WhatsApp channel. The QR code is on the screen now. In the end, this video is for general education purpose only and it does not constitute medical advice, diagnosis or treatment. Individual presentations vary significantly and all treatment decisions should be made in consultation with a qualified healthcare professional. This video does not create a doctor-patient relationship. See you in the next video, video number 5. Goodbye.